Okay, so we're back. We're doing part 2 today of vascular pressure monitoring. So this is Thursday's lecture, the 23rd. All right. Okay, so we're going to be talking mainly today about CVP line, central venous pressure monitoring, and wedge pressure, Swan-Ganz. So you're going to see there's definitely parallels as far as the different pressures and complications and that with any type of invasive line here. So this is hopefully not going to be too terribly lengthy. It's going to be longer than yesterday's, but so just hang in there. All right, so when we look at a CVP or central venous pressure, we're really looking at the pressures of the right side of the heart. Okay, so it measures pressures of the blood in the right atrium or the superior vena cava, where the blood is returned to the heart from the venous system. Right, so this is kind of monitoring the right side. So some of the different indications are to assess circulating blood volume and filling pressures of the heart, okay, to assist the right ventricular function. Patients who have had major surgery or trauma might need a CVP, or patients with pulmonary edema often can benefit from a CVP. So keeping in mind that your CVP equals the pressure in the right atrium or the vena cava. The CVP also represents the end diastolic pressure in the right ventricle and reflects right ventricular preload or the filling volume. Okay, so CVP represents the end diastolic pressure of the right ventricle and reflects right ventricular preload. Because the tricuspid valve is opened between the right atrium and the ventricle during diastole, during that filling period. Okay, so it's also the tricuspid valve is open, so it reflects also the RVEDP, right ventricular end diastolic pressure. Okay. So it tells us the degree basically of venous return. And why do we care about that and what types of patients? So our ventilator patients, definitely. Patients that are in sepsis, those patients might need fluid because they're in shock, and they may go into pulmonary edema when we administer that fluid. That's one of the drawbacks, the things that you have to be careful of. And those types of patients may need a CVP. Okay. And then, of course, positive pressure can affect the venous return, so we have to be mindful of that also. So when we're looking at the catheters, the most popular is a 7 French with a triple lumen, one distal port with 2 other ports that are about 3 to 4 centimeters from the distal end of the catheter. So the triple lumens then allow for infusion of medications, and it also allows you to draw blood, okay, from that line. Some of the common sites to put a central line is, so a CVP and a central line is the same thing. It ends up in the right atrium, goes through the vena cava, and then ends up in the right atrium. So some of the common sites are the subclavian in the internal jugular veins. Okay, so it's put in through the venous system. All right, so we're going to talk a little bit about some of the advantages and disadvantages of the different places of the subclavian in the internal jugular. Okay, so an advantage of putting it in the subclavian is that it results in a much more stable placement. Okay, it can be difficult to place. Okay, it's more difficult to place because the subclavian vein runs along the subclavian artery, which then therefore could easily be punctured. And the pleural space isn't too far below the vein, so pneumothorax is also a potential complication. So you definitely want to make, check a chest x-ray after placement, and, check your ventilator, make sure, pressures haven't gone up, and that type of thing. So just be mindful if they're putting in those lines. Also, be checking for any sub-Q. Internal jugular is really the easiest because it's a straighter shot, basically. There's a less risk for pneumo and hemos, and it's easier to see and control. However, once it is placed, even though the placement itself is easier and there's less risk of puncturing things, the catheter is in a less stable placement. It's more subject to kinking, breakage, accidental removal. So another place they may put it is the femoral vein. So just kind of know your pros and cons of each of those vessels. Just a picture of a triple lumen that you may see. Again, it's placed through the internal or external jugular vein. The tip ends up in the right atrium, and the catheter does not have a balloon. There's never ever do you inject air into those ports. Alright, so here's kind of a picture. This is again following chapter 15 out of Wilkins. So where they place it in the jugular for this particular picture, and then as you can see it goes into the superior vena cava and lands in the right atrium. So the tip then is positioned in the right atrium. So CVP is your right atrial pressure. And then the monitor scale, next slide. Monitor scale then is set at between 0 and 30 millimeters of mercury, and the pressure transducer must be placed at the level of the patient's right atrium. That is the phlebostatic axis, P-H-L-E-B-O-S-T-A-T-I-C, phlebostatic. Okay, that PHF sound. If the transducer, so this is kind of similar again to the art line that we were talking about. If the transducer is placed below this phlebostatic axis, you're going to have too high of CVP readings. If the transducer is placed above the phlebostatic axis, the reading will be too low on your CVP. Okay. Right. So this, the CVP is going to actually produce waveforms. Okay. So it's going to reflect the pressures in the right atrium, and there's, it's going to be, I think, on the next slide, but you'll have different waveforms here. Mainly naming 3 of them, but the next slide talks about a couple other ones. So we have the A, C, and the V. Okay, so your A is basically representing being reflective of your atrial contraction. Okay, so think of it as atrial contraction. Your C wave occurs with the completion of the AV valve closure, so the valve between the atrial and the ventricle closure. It represents the movement. I think I was supposed to type in, I just fixed this too. Movement, it should say movement or, I'm sorry, or bulging. Okay, movement or bulging of the AV valve back towards the atrium during that ventricular contraction. Okay, so I have to fix that. V then is what is showing them with atrial filling during systole. Okay, so your V also is your atrial filling. Right, let's look at the next slide. Yeah, so here we go. Here's the 3, and you guys should have, if you look at the regular view for that we do in the classroom, the PowerPoint, or the regular PowerPoint without the audio, this should be in the speaker notes. Okay, and goes into a little bit more detail. I'll just kind of read these off here. So again, the A wave is the atrial contraction, occurs during ventricular relaxation. The C is completion of the AV valve closure, okay, represents the bulging of the AV valve back towards the atrium during ventricular contraction. Then your X is like a descent, so you can see how that's sloping downward, and that is wave results from the decrease in the atrial pressure as the blood is moving into the ventricle, and then it ends with the closure of the tricuspid valve. And then your V wave is your atrial filling while the AV valve is closed during ventricular systole. And then the Y then is a descent. Y descent is then the tricuspid and the mitral valve opening, and the ventricles are beginning to fill with blood. Okay. I'm just going to add a couple more things that you can kind of add to your notes, and you'll kind of see it in the slide. I think it's coming up. Yeah, it is actually coming up, the next one. Maybe I'll just move to the next slide and you can kind of see. Okay, so when you look at the A, because it kind of shows it here, if you're looking at the top one, the A, C, V, Y, you can see how the A kind of correlates with your PR interval. Okay, so the atrial contraction again. And then your C wave is again the closure of the tricuspid valve, which kind of correlates then with the QRS. And then your V wave, again the atrial filling, which correlates then to the early T to P interval. And then again your X, you don't really see it on this one. Oh yeah, you do on the lower one, on the CVP there. The X again is atrial relaxation, okay, and then Y, the Y descent is where the tricuspid valve reopens. Okay, so be more familiar, I guess, as far as a test question, because I know you're saying, do I need to know all these? Just be familiar with A, C, and V. Okay, A, C, and V. Alright, so you're going to see some variation in respirations in your CVP. So spontaneous inspiration efforts are going to cause your CVP to decrease, and those are going to be seen on the waveform. And then positive pressure breaths then are going to cause the CVP to increase. Okay, so spontaneous inspiratory efforts cause the CVP to decrease. I hope I said that right the first time. And are going to be reflective on the waveform, and then positive pressure breaths are going to cause the CVP to increase. So CVP monitoring during mechanical ventilation requires sometimes a brief disconnection of the ventilator unless PEEP is being applied, and we generally always have PEEP, so you don't really have to worry about that. I maybe years ago I've done it when somebody was doing a measurement, but I don't remember doing it for forever now. I think back at it. All right. I'll be so glad we're back in class. Ugh. Okay, here we go. Sorry. Respiratory variations continuing here. So the absence of respiratory oscillations on a tracing might tell you that you need to kind of look and see if there's a measurement error that might require some troubleshooting. So you might want to, kind of look and see what's going on. The most likely cause could be a kink or air in the tubing, or possibly the stopcock is turned in the wrong direction, or there's a small clot or kink. Rarely, when a hypovolemic patient is breathing spontaneously at small tidal volumes, respiratory oscillations may not be apparent, and you might not see your typical A, C, and V wave. Okay. So rarely when a hypovolemic patient is breathing spontaneously. What you can do is you can ask them to take a deep breath, then the waveform should fall below baseline as the intrathoracic pressure falls with inspiration. Okay. CVP in all pulmonary artery pressure measurements should be obtained at end expiration. Okay, you guys should probably know that by now from other classes and vent stuff, but CVP in all pulmonary artery pressures need to be taken at end expiration. That will be a test question. Alright, so we have different methods of monitoring the CVP. There's a transducer system, which is probably the most accurate and provides the waveform, and that's probably what you're more likely going to see. There's also a water manometer. It's inexpensive, easy to use, but I haven't seen that used forever. I think it's outdated. So when we're looking at things, we're trying to interpret our CVP. So kind of keep in mind, CVP is regulated by a balance between the volume of blood returned to the heart, the venous return, and then the ability of the right heart to pump this blood back out into the pulmonary circulation. Okay, I'll say that one more time. CVP is regulated by a balance between the volume of blood that's coming back to the right heart, okay, to the heart, your venous return, and then the ability of that right heart to pump the blood back out into the pulmonary circulation. Okay, so things that can cause an increased CVP could be fluid overload, okay, you have too much volume, right or left heart failure, because if the left heart's failed too, it's going to back up. Pulmonary hypertension, you're not able to push, the blood out. It's, you have a smaller, constricted vessels in the pulmonary system. Tricuspid valve stenosis, pulmonary embolism, and increased venous return. Causes of a decreased CVP then would be reduced circulating blood volume, so I'm thinking like low hypovolemia, okay, dry, vasodilation, so reduced venous return, so maybe the volume is there but you're just vasodilated, could be septic, I'm thinking, leaks in the pressure system, okay, spontaneous inspiration. Alright, so this is where that Cheetah tool, the non-invasive fluid status monitoring tool comes in handy, and you might see that out there. I have a feeling you're more likely to see that than you are a swan. Okay, so it works in patients with poor perfusion and low CVP. A fluid challenge may be given to determine whether the cause is hypovolemia. They may give a kind of a fluid, like a bolus of 200 to 500 mils over about 10 to 15 minutes. If the CVP does not change, this can indicate poor perfusion due to hypovolemia, so the patient may need more fluid. If the CVP does increase by 2 millimeters of mercury or more, hypovolemia is unlikely, and then caution should be used with administration of more fluid. Okay, so if the CVP does increase by 2 millimeters of mercury or more, hypovolemia is unlikely, and caution then should be used with administration of more fluid, because if you end up administering more fluid, you could this can lead to third spacing, which will make it harder for us to ventilate, and pulmonary edema, and CHF. Okay. All right. So causes of changes in the CVP. So increased pressure. Okay. So if we have increased pressure, volume overloads or fluids can be given more rapidly than the heart can tolerate. So that's going to cause increased pressure. So these are things that have caused increased pressure. So we've given too much fluid too rapidly. We've increased intrathoracic pressure, has increased with positive pressure breath or tension. There could be some compression around the heart caused by a pericarditis or a tamponade. The patient could be developing pulmonary hypertension or have hypertension, pulmonary hypertension, right ventricular failure could be going on, or left heart failure, which then will eventually cause right heart failure. Some other things that could cause the CVP to be elevated is pulmonary valvular stenosis, tricuspid valvular stenosis or regurg, a PE, increased large vessel tone throughout the body, so you're constricted, arterial vasodilation, which then is increasing the blood supply to the venous system, so it's trying to compensate, infusion of solution in the CVP line, placement of the transducer below the patient's right atrium and the phlebistatic axis. Some causes of decreased pressure: vasodilating, inadequate circulating blood, dehydration, bleeding, GI loss, wound drainage, perspiration. I always think they must have to really sweat a lot, maybe a lot of trouble with fevers or something. Urine output, losses to the interstitial space, other types of sensible losses. Spontaneous inspiration, this is again continuing with decreased pressure. Placement then of the transducer above the right atrium of the phlebistatic axis, or air bubbles or leaks in the pressure line. Okay, so CVP rises as the efficiency of the right heart to move blood through the lung decreases. Okay, so CVP rises as the efficiency of the right heart to move blood through the lungs decreases. So the right heart has become weaker, basically. When the CVP is elevated while pulmonary arterial pressures are normal or low, the cause of the problem is the right heart. So you could have a right ventricular infarction or tricuspid stenosis and regurg. So when the CVP is elevated while the PAP pressures are normal or low, the cause of the problem is in the right heart. Okay, so it's either right ventricular infarction or some type of stenosis or regurg. If both CVP and your pulmonary artery pressures are elevated while the left-sided filling pressures are normal, then the problem is most likely in the lungs. And I know that's in Wilkins because I have a page note, but unfortunately it is from my old edition. Let me see if I can look at it really quick. I'm going to put you on pause. Okay, so it looks like in your Wilkins, page 339 and 340 is kind of where this is discussed. So hopefully that'll help clarify. If you have any questions, sometimes it's helpful to definitely see it in print so you can kind of, for me anyway, to kind of regurgitate it a little bit better or absorb it, I guess. I have to reread it or break it down. I do better if I rewrite my notes. I kind of hope you do that, or at least highlight things. All right, moving on. Complications of CVP monitoring. So just like anything else, this is what I was talking about before. Like, during placement with any type of invasive line, you run the risk of bleeding, pneumothorax, especially if you're around the chest wall. Also infection is your main problem. Embolism, an air embolism, both blood clot or air. Arrhythmia, so make sure you write that down. Arrhythmia can also be a complication. All right, so before we move on to pulmonary artery pressure monitoring, I just kind of want to recap again. So what does the CVP pressure represent? Okay, overall fluid status, you can say, more specifically, and diastolic filling pressures. Okay, it's on the right side of the heart. Normal CVP is about 2 to 6. Okay, 0 to 8 you might see, 2 to 6, either one. Okay, I have 2 to 6 written down, but I've also seen 0 to 8 millimeters of mercury. Okay, so remember CVP is equal to right atrium pressure. All right, anything that decreases the amount of blood returning to the heart decreases CVP. And the flip-flop, anything that increases venous return is going to increase your CVP. So remember, if your CVP is high and the other pulmonary pressures are low, the problem is the right side of the heart. If both are high, the problem is usually the left side of the heart because of fluid backup. Okay, and remember, you take the measurement of a CVP measurement, it should be done at end expiration. All right, moving on to pulmonary artery pressure monitoring, or this is basically your SWAN, okay, SWAN GANs. So, just a little bit of history here. This was developed by doctors Swan and Gans in the late 1960s. Okay, so you may see it pulmonary artery pressure, or PAC, pulmonary artery catheter. Okay, so it's pulmonary artery catheter, or PAP, pulmonary artery pressure, but just so you mean, pulmonary artery catheter and SWAN is the same. All right, so this is to look at, to evaluate the left ventricular function. Okay, so the catheter is placed in the patient's pulmonary artery and allows assessment of left ventricular filling pressure, which then helps determine left ventricular preload and cardiac output. Prior to them coming up with the SWAN, they had to actually go to the cath lab to do this. Okay, so before this was developed, you actually had to take a patient to the cath lab to get these measurements. So it also allows us to look at pulmonary vascular resistance, our AV oxygen difference, arteriovenous oxygen difference, which can reflect then our tissue oxygenation. It looks at mixed venous oxygen levels, which is the proportion of left to right shunted pulmonary blood flow. Patients responsive to vasoactive agents, fluid, and positive pressure ventilation. So your SWAN GANs is going to be a balloon-tipped, flow-directed catheter. Oh, I had to take a quick break. I'm back for a second. Sorry to abandon you in the middle of the slide. We just got a package. So anyway, as I was just kind of looking at my notes again here, so another assessment there is looking, I think I kind of rolled it all into one. So when I was saying mixed venous oxygen levels, so again looking at the proportion of left to right shunted pulmonary blood flow, also looking at patients' response to vasoactive agents, fluid, and positive pressure ventilation. So that's another list, and that allows assessment of patients' response to vasoactive agents, fluid, and positive pressure ventilation. All right, moving onward here. So why do we do SWAN GANs or PA pressure monitoring? Well, I thought it was kind of funny. It says indications are not well defined. It's basically one of those things where I think I've said before, the benefits have to outweigh the risk. Okay, it's really a case-by-case basis, looking at seeing, of course, the patient's condition, if your staff is qualified. Is it really going to change the outcome? Is it going to change the treatment? Or is there any other way that we can get these values without having to do? I would say over the last probably, 5, probably more like 10 years now, because time flies by so fast, they really have gotten away with any kind of invasive, the less invasive the better. Okay, so, but I really do hope you get a chance to see that, just like the SVO2 monitoring. I thought that article was good, by the way. Okay, so here are some conditions where they might want to consider it. Severe cardiogenic pulmonary edema, where they're just really having trouble, or sepsis, severe cardiogenic shock, where they're just having a lot of issues with the blood pressure. Patients with ARDS, again, hemodynamically unstable. Patients who've had maybe major thoracic surgery. So it might be something that they may end up putting in the OR. Maybe they were having trouble with pressure, maintaining blood pressures, and they wanted to know the numbers. And what better place to put it in the OR? They already have a sterile field established. They have the staff there to put in those lines. So again, the benefits must outweigh the risk. So pulmonary hypertension, they can also get nitric oxide along with this Swan-Ganz as far as a treatment option. Be careful with putting in a Swan if a patient has a history of PVCs, A-flutter, VTAC, internal AED. A Swan might not be a good choice just because it's going to make the heart more irritable. Just putting that line in itself is going to make the heart more irritable. All right, so this is a picture out of your textbook again. It is again a balloon-tipped flow-directed catheter. The balloon holds a maximum of 1.5 mils or 1.5 cc's of air. Okay, that is a test question. This is an idealized PA catheter. No catheters have all these features, but in the perfect world they would have all these features that are shown on this diagram. So they do have multiple lumens, and again they're balloon tipped. The balloon is basically used to float the catheter in place and to help measure the pressures once it's inflated. Again, the most common sites for insertion include very similar to the CVP, your subclavian and internal jugular veins. Okay. The catheter is floated through the right side of the heart, same as a CVP, but then it travels further into the pulmonary artery. Okay. Once it is wedged into place, then the balloon is deflated. So once they get into the right atrium, or when they get into probably even maybe the vena cava, they inflate it. I know for sure the right atrium, because then the blood flow itself helps kind of float it around. So you think of it as just this little balloon kind of floating around in your heart. Scary thought, really. And I gotta find this one video that I mean, it was just kind of more funny than anything about this guy talking about putting in a swan, but and all the horrors associated with it more than anything. But anyway, so once it gets in place, then they deflate the balloon, because if you were to leave that balloon inflated, I mean, you inflate it temporarily to get your measurements, but you need to deflate it because basically the balloon can obstruct or cut off the circulation. Okay, so as it's traveling through the right atrium, the right ventricle, the pulmonary artery, into the wedge position, further down the tree or the branch of the artery, it produces waveforms as it's floating, and that kind of helps to identify where it is, the location of where they're at as they're positioning it or inserting it. And those waveforms look something like this, and this is definitely out of your text. Put this underneath your pillow and sleep on it so you get this all memorized. You want to know these numbers and what you're looking at. When you see like a screenshot of something or a test question or whatever, you want to be able to tell me what this is and where they're at. So you have to bear with me here because I have a lot of notes written on this slide. So on the left one there, the right atrium. Okay, so again, normal pressure is about 2 to 6. So your right atrium pressure equals what? Your CVP. I think I heard you. And if you look at that, that waveform is really similar to that CVP waveform. You have your A and your C and your V, okay? So again, there's distinctive waveforms are seen as the catheters pass through the right atrium, right ventricle, and pulmonary artery into this wedge pressure. So then as it travels then from the right atrium, we're going to obviously have higher pressures, okay? We have more pressure going on in the right ventricle. So we have a normal range of our systolic being about 15/30 to 2/8 diastolic, okay? And you can see on that one, it actually drops to 0 during diastole. That's when the ventricles are relaxing, okay? So it's kind of like that contraction where you're getting the higher pressure and then down to relaxation. Then it goes further along into the pulmonary artery, where again the pressures are about, again, 15/30, over a little bit higher on the diastolic because your vessel is narrower there, and so 8-15 on the diastolic with a mean of about 9-18. Okay, and this pulmonary artery pressure, this pulmonary artery waveform, is really a miniature of the arc line pressure of your peripheral artery waveform that even has a dicrotic notch, okay? And then as you travel further, then it gets to your pulmonary capillary wedge pressure, okay? After it branches off, the pulmonary artery branches off before it gets into the lung there. And then you have that wedge pressure normal of about 6-12, okay? And that also resembles a CVP waveform. So the balloon tip, I'm sorry, hold on. So the balloon is inflated when the tip reaches the superior vena cava or the right atrium, like I said before, and then it helps it float. The wedge position is reached when the balloon arrives at an artery that is too small to allow further advancement to the catheter. Well, that's where it can be kind of dangerous because you certainly don't want to puncture a pulmonary artery. So when the balloon is inflated, okay, when you're actually trying to get a measurement, the tip then reflects the back pressure from the pulmonary venous system and left atrium. When the balloon is deflated, it should look more like pulmonary artery pressure, okay? So this is in Wilkins, this whole diagram is in Wilkins, chapter 15. All right, so kind of what are we interpreting here? So the PA, the systolic, the higher one, is the highest pressure created when the right ventricle ejects blood through the pulmonary valve into the lungs, okay? So normal being about 20-30, it's going to obviously increase with high pulmonary vascular resistance. It's going to decrease with poor right heart function and pulmonary vasodilation, okay? Your PA diastolic then is about 8-15, okay? So even this kind of the picture says 15-30, and this says 20-30, so you can always see there's a little bit of variance there. So again, normally reflects the left heart filling pressure, does not reflect left heart filling pressures when the pulmonary vascular resistance is elevated. So when we look at the first statement there, again talking about increases of pulmonary vascular resistance, kind of thinking about things that increase your PVR, okay? Resistance to pulmonary blood flow, okay? So I think of things like constriction, okay? So this can be caused by constriction of the vessels, obstruction or compression of the pulmonary vasculature, or by back pressure from the left heart, pulmonary embolism, acute or chronic lung diseases that causes pulmonary constriction and responds to hypoxia. Okay, left heart failure, mitral valve regurg causing back pressure from the left heart into the lungs. Okay, I'll say that again. So examples of increasing your PVR, and you should have this from before when we were talking about more of the vasculature system, can be caused by constriction, obstruction, or compression of the pulmonary vasculature, or by back pressure from the left heart. So more specific examples of pulmonary embolism, acute or chronic lung disease that causes pulmonary constriction in response to hypoxia, left heart failure and mitral valve regurg causing back pressure from the left heart to the lungs. So the next thing I'm going to talk about covering on this slide is on page 332. There's like this box chart kind of thing, diagram, whatever you want to call it. It's not a table, but it kind of talks a little bit about, read through that because I think it's important. Again, page 332. So pulmonary hypertension, okay, causes pressures to increase in the right heart and eventually the venous system, which increases lung pressure that leads to an increase in pulmonary artery pressures that lead to an increase CVP and an increase in venous congestion. So if we look at pulmonary hypertension, okay, and how it eventually causes pressure to increase in the right heart, and eventually causes the venous system. So what happens is we have the increased lung pressure, which is our pulmonary hypertension. So we have an increase in that, and then that's going to back up, right? So think of it flowing kind of backwards now. It's going to kind of dams up, increase your PAP, which then is going to lead to an increase in CVP, which then is going to lead to an increase in venous congestion. Okay, so looking at the other, if we have a failing left ventricle, this is going to cause blood then to dam up in the left heart, then the lungs, and eventually the entire system. So if we have an increased in left atrial pressure, we're going to then have an increase in pulmonary artery wedge pressure. Again, this is backing up, increase in PAP, increase in CVP, and increase in venous congestion. So this is all kind of drawn out or sketched out or however with all the arrows and stuff in page 332 in Wilkins. So read through that, try to kind of wrap your head around it. I know it's a lot. All right, so normal wedge, about 6 to 12. Have to be kind of take in consideration the patient's history. If they have a history of an MI, it's going to cause a stiff left ventricle and it's going to show higher pressures. We're going to have it elevated with left heart failure or mitral stenosis. It's going to obviously decrease with hypovolemia. So we need to kind of see what the underlying condition of the patient is, because some of those values have to be relative to what is going on with them. I mean, maybe that's their baseline pressure. Now is it worse or better or whatever. So we have to kind of have the overall picture of what's going on with the patient. So you're going to hear wedge pressure can be called pulmonary capillary wedge pressure, so PCWP, or even PAOP, pulmonary artery occlusion pressure. And they get that because they occlude it, for a short amount of time when they're inflating that balloon. All right, so we need to make sure that everything is calibrated and that we're measuring at end exhalation. Okay. The catheter tip must be in the West Zone 3. And what the heck is that? I tell you, the first time I taught this class, I was like, what are they talking about? West Zone 3. It's just a person's name. West is a physician's name that came up with these zones, so don't worry about it being a certain direction or something. It's just what it's called. And we'll look at those zones here in just a minute. It should be really a review. So the zone 3 is where the blood flow is continuous. Low blood volume and high alveolar pressures can cause the wedge pressure to be inaccurate. Okay. I'm going to tell you something here that is on the final. So when a patient is on a vent to correctly read the wedge pressure, okay, the RT or RN, whoever's in charge of the swan, would inflate the balloon with no more than 1.5 mils of air and then record the reading at end expiration. Okay, so when the patient's on the vent, to correctly read the wedge, you need to inflate the balloon with no more than 1.5 mils of air and record the reading at end expiration. Alright, so here's a review of the snapshot there of your different zones and the pressures. Remembering that the PA, big A, is alveolar pressure. So in zone A, we have alveolar pressure is greater. The air goes, that's gravity dependent, supposedly you're standing upright. And then that would be greater than your arterial, which then would be greater than your venous, and then so on as you continue to read it with. So basically in zone 1 you have no blood flow because the alveolar pressure is greater than both the venous and artery pressure. In zone 3, because breathing and pulmonary artery pressure, systolic and diastolic are phasic, your flow is more intermittent in zone 2, and your pulmonary artery catheter is wedged in zone 3, where both PA, your arterial, and your venous are greater than your alveolar pressure, resulting in uninterrupted flow to the left heart and a wedge pressure that reflects pulmonary, venous, and left heart pressure. So that's why it's obtained in zone 3 there. Or the catheter tip must be in zone 3. Alright, a couple more slides. You're hanging in there, doing a good job. So different complications. Obviously when placing it, the pulmonary artery catheter, you can have a hemo or a pneumo, damage to other blood vessels, dysrhythmias can definitely occur. The catheter itself is a source of infection or blood clots, bleeding, hematoma, even possibly a pulmonary infarction could happen. This is just kind of like bundles practice, making sure that we reduce the incidence of infections and anything that's invasive. A multidisciplinary approach, making sure everybody's involved. Importance of hand hygiene, maximal burial precautions, cleaning the skin site, looking at the lines, having the optimal place for it to be inserted. Alright, so this is just a quick summary. We need to look at hemodynamic monitoring, as can be common in the ICU, to help identify cardiovascular problems, to make sure we're measuring effectiveness of therapies. Continuous, so your art line, your CVP, and your swans are available. Having to definitely look at the risk-reward assessment to see whether or not these are something that we want to pursue. Okay, the next time we'll be talking a little bit about, actually a lot of it, of EKG stuff.